So you're working, right? So you're working, right? How crisp is the audio? Okay. So again, this is my microphone, and this is my tablet. And no matter what happens, I can just teach whatever I need to teach, and yeah, it'll be quite good. So I have to get through 144 pages, and I'm just going to go by and try and explain whatever I can. I'll make some notes over here, and let's just see how this goes. So starting off, unfortunately my Apple Pencil, it's not such. Just a second. Yeah, so honestly this app kinda takes the cake, if you can say. Unfortunately, yeah, my Apple Pencil is not exactly charged right now, so I'll have to teach a little bit and I'll come back and I'll teach a little bit more. Again, yeah, 144 pages, so let's get on. Today I'll finish medicine 1, tomorrow I'll do medicine 2, and after tomorrow we just keep on doing question papers for the next 2 days. So as you can see, it's Friday the 4th of April and it is 7:14 p.m. Okay, so acute pancreatitis, you have, first of all, I get ASHD, which is infections, gallstones, ethanol, trauma, autoimmune, scorpion string, hyperlipidemia, hypercalcemia, ERCP, and drugs, which is steroids, valproates, azathioprine, and thiazide diuretics. So, of course, acute pancreatitis is inflammatory condition of the pancreas characterized by abdominal pain, elevated levels of pancreatic enzymes in the blood, and you can also include post-surgical cystic fibrosis, toxins of scorpion venom and all, renal failure, serious hypothermia, severe hypothermia. Sorry. So pancreatitis, of course, first you have pancreatic injury. They release the inflammatory mediators, which are TNF alpha, interleukin 1, which again lead to premature activation of the cymogen granules, which leads to trypsinogen activation by enterokinase into trypsin, and finally it leads to activation of protease, phospholipase, elastase, and digestion of pancreatic and surrounding tissue, which may lead to severe inflammatory response syndrome and MODS. I forget what mod is. Multiple organ damage syndrome or something like that. But several organs should be done. So trypsinogen activated by the intrakinase into trypsin. Swollen pancreas with hemorrhage and necrosis will be seen. This activates protease and phospholipase 2 and elastase. So symptoms, you have nausea, vomiting, hiccup, relching, oliguria, and Muhammad Prayasin. Or you can say they drink like a wolf, kill like a cheetah. There are stuff like that. Burrow like a rodent. Um, what more was there? There's no more things which is there in another textbook, but yeah, there are stuff like that. So you have signs which is tachypnea and hypotension, tachycardia, facial flushing. You have Turner sign, you have Cullen sign, which is Turner sign is hemorrhagic pigmentation around the flanks. Cullen sign is pigmentation around the umbilicus. Then you have Fox sign, which is inguinal ecchymosis. So tachypnea, they'll be breathing very rapidly. Hypotension, they will not be having blood pressure proper. Tachycardia, increased heart rate. There will be facial flushing. Fever will be there. Jaundice because of the compression of the common bile duct. And you have epigastric tenderness. Turner sign is a hemorrhagic pigment in the flanks. Cullen sign is pigmentation around the umbilicus. Fox sign is inguinal ecchymosis. So complications, you have pancreatic necrosis, fat necrosis, acute colon necrosis, disseminated intravascular coagulation, ARDS, hematemesis, melena, and splenic vein thrombosis. So investigations, you have pancreatic amylase, calcium, lipase, lactescence, serum trypsin, amylase creatine ratio, trypsinogen activation peptide, TAPase, phospholipid A2, glucose, hyperglycemia, LDH levels, etc. So in ultrasound abdomen, you can do spiral CT, you can do chest X-ray, abdominal plain X-ray will be there. The colon cutoff sign will be there, in which there is like ascending transverse colon distension will be there, but descending colon collapse will be there. There will be a renal halo, there will be obliteration of the source shadow, and there is also a localized ground glass appearance. So management, you admit them into ICU. Analgesics, you give metamizole, buprenorphine, and antibiotics in case of cholangitis. Enteral feeding for nutrition, radio fluid therapy, ringer lactate. Supplementary oxygen is provided. Monitoring of the urine output and blood gas analysis must be done. You can monitor RFT, LFT, coagulation profile, serum calcium, blood glucose. So gallstone pancreatitis, you have to do ERCP within 72 hours with common bile duct stenting. Then laparotomy, you have neurosectomy, and you have continuous closed peritoneal lavage. Surgery is indicated in case of pancreatic necrosis, pancreatic abscess, interstitial obstruction, and um, interstitial obstruction and perforation. So prognosis of acute pancreatitis, you have Ranson criteria. Main thing, which is if it is more than 3, it is severe acute pancreatitis and increased mortality. On admission, if the age is more than 70, blood sugar is more than 220 mg percentage, LDH is more than 400 international unit, and H levels as per determinants levels is more than 250. This is the Ransom criteria. Within 48 hours, there is hematocrit drop more than 10%. Blood nitrogen reaches more than 2 mg percentage. Serum calcium is less than 8 mg percentage, and fluid sequestration if more than 4 liters, then it is Ransom criteria, acute pancreatitis. So severe acute pancreatitis risk factors is common in more than 70 years. BMI is more than 30. It is associated with shock. It is having respiratory failure, renal failure, GI bleeding, multi-organ failure. Ransom score is more than 3, and Apache 2 score is more than 8. This is for severe acute pancreatitis. Do we have any chat? No one. Oh. Yeah, okay, so acute pancreatitis causes a scorpioning damage, injury, pancreatic injury, infections, gallstones, ethanol, trauma, autoimmune SLEPA, and scorpion stream, hyperlipidemia, hypercalcemia, ERCP, anorexia, provide 65% post-surgical toxins, renal failure, and severe hypothermia. All of them are relating to pancreatitis. Necrosectomy. You have to admit into the ICU. You have to give analgesics, metamazole, buprenorphine. Provide analgesics, antibiotics, actual feeding for nutrition, fluid therapy. You have to give fluids as a main part. Yes, you have to supplement oxygen. You have to monitor the urine output, the blood class analysis, and you have to monitor RFT, LFT. You have coagulation program profile, serum calcium, blood glucose. So gallbladder pancreatitis, you have to do ERCP within 72 hours with common bile stenting. So laparotomy, you do necrosectomy, and you have continuous peritoneal lavage. Am I clear? And next we go on to chronic pancreatitis. Chronic pancreatitis is persistent inflammation of the pancreas with permanent structural damage with fibrosis and ductal structures, followed by a decline in exocrine and endocrine functions of the pancreas. So if it is pancreatic insufficiency is seen in chronic pancreatitis. So it is caused by alcohol, tropical and pancreatitis, obstructive pancreatitis, autoimmune pancreatitis, hyperlipidemia, hyperparathyroidism, trauma, cystic fibrosis, oxidative stress hypothesis, which is chronic reflux of the bile will lead to pancreas damage. You have toxic metabolite theory, which is alcohol directly damages pancreatic acinar cell. And you have stone and duct theory. Alcohol increases the lithogenicity, which leads to stone formation and duct obstruction, all leading to chronic pancreatitis. So mainly alcohol has come in a lot of places. Tropical pancreatitis, obstructive pancreatitis, autoimmune pancreatitis, hyperlipidemia, hyperparathyroidism, you have trauma, you have cystic fibrosis. And clinical features, you have abdominal pain, you have diarrhea, you have steatorrhea, white color stools. The patient is a thin, malnourished patient with epigastric tenderness. Epigastric tenderness, you have to remember. And you have skin pigmentation over the abdomen and the back due to chronic use of the hot water bottle to sterile. That skin pigmentation may not be required. Then diarrhea, steatorrhea, malabsorption, endocrine disruption. You have brittle diabetes, insulin deficiency leading to diabetes mellitus, and glucagon deficiency. So exocrine disruption will be there. Mass per abdomen, tender joints will be there above the umbilicus. Malleus sign will be there, where in the right knee chest position there will be tenderness on the palpation of the left hypochondrium. So classical triad of chronic pancreatitis, you have pancreatic calcification, you have steatorrhea, you have diabetes mellitus. Calcification, steatorrhea, diabetes. That is a chronic pancreatitis. Malleus sign is right knee to the chest position. You have tenderness on the palpation of the left hypochondrium. The other side, because you just push the pancreas from one side to the other side. That's what I will feel. Exocrine disruption, of course, diabetes mellitus. Endocrine exocrine disruption, basically malabsorption. Endocrine disruption, you have brittle diabetes, you have insulin deficiency, and you have glucagon deficiency. The insulin deficiency leads to diabetes mellitus. So complications, you have pancreatic pseudocyst, you have pancreatic ascites, you have pancreatic fistula, you have carcinoma of the pancreas, you have portal vein thrombosis, and left-sided pleural effusion. So differential diagnosis can be carcinoma head of the pancreas leading to all the obstruction and features. Retroperitoneal tumor may be there, which is obstructing. And investigations, you have blood glucose, liver function test, stool examinations in which you have fecal elastase, which is less than 200 microgram per gram, and steatorrhea may be there, wherein it is more than 7 grams in a day. So secretin cholecystokinin test also is a test in which you access the pancreatic function. ERCP is there, which there is a chain of lake appearance. ERCP on extrarenal colpoperenography, you have endoscopic retrograde cholangiopancreography. You have chain of like appearance in the ERCP. I forgot what CT is actually. That's kind of a mess. So in CT abdomen, computer topography abdomen, you have pseudocysts, you have calcification, you have ductal stones. CT abdomen, you can diagnose them. EU is endosonography, you have malignancy, you have duct status, and you have common bile duct status. You have to check. So treatment, you can have conservative treatment in which you have to avoid the alcohol, you have to eat a low fat diet, you have to use analgesics, you have pancreatic enzyme replacement therapy, and you have controlled the diabetes using insulin. Then surgery. You can do drainage procedure where you have Pew-Stowe procedure, Whipple's procedure, Burgess procedure, Fraser procedure, Burns procedure. All of them you can do. But Whipple's procedure is, I think, the one thing which is done for pancreas, I feel. You also have a partial pancreatic resection or total pancreatectomy. But total pancreatectomy is most common, and drainage procedure is all these procedures. People just take the pancreas and you attach it directly to one end of the jejunum. I think, if memory serves me right, I forgot. Which is something you don't want a tutor to say. Dyspepsia. Dyspepsia is corrective syndrome of variety of gastrointestinal symptoms. You have upper abdominal pain will be there, in which there is early repetition or satiety after meal. You have GERD and heartburn. You have anorexia, nausea, and vomiting. Abdominal distension or bloating can be seen. Flatulence, burping, blanching, aerography can be seen. They'll be burping a lot, blanching a lot, aerography. Abdominal distension or bloating will be there. Anorexia, nausea, and vomiting will be there. GERD, heartburn, same thing. Same symptom, early depletion and satiety after the meals. Basically, this is dyspepsia, upper abdominal pain. Then it is caused by it may be functional dyspepsia, wherein it's like a psychiatric disorder, and doesn't really, it cannot actually be cured. It can be dyspepsia associated with organic disease of the upper GI tract. I may need to charge you in a bit. Okay, now you have dyspepsia associated with organic diseases of the upper GI tract, which may be peptic ulcer, it can be peptic esophagitis, gastroesophageal reflux disease, GERD, it can be gastric carcinoma, it can be lactose intolerance. So we also have dyspepsia associated with other conditions like pancreatic disease, which is pancreatic diseases, you have Crohn's disease, you have colon malignancy, you have cardiac, renal, and hepatic failure, and carcinoma of the lungs. Drugs can be caused by acarbose, metformin, miglitol, bisphosphonates, NSAIDs, and corticosteroids. NSAIDs, corticosteroids, they are like painkillers. Miglitol, bisphosphonate, and metformin, acarbose also, they are all anti-diabetic drugs. So metformin and bisphosphonates, you remember. Dyspepsia associated with other conditions, Crohn's, colon malignancy, Crohn's, of course, you'll be having ulcers and all everywhere. Pancreatic diseases, you'll be having dyspepsia. We told before itself. Cardiac, renal, and hepatic failure, you have to somehow remember. Carcinoma of the lungs also, you have dyspepsia. Associated with organic lesions of the upper gastrointestinal tract, you have peptic ulcer, you have peptic esophagitis, gastroesophageal reflux disease, gastric carcinoma, lactose intolerance. All stomach problems will lead to dyspepsia. All these stomach problems. Again, you have anxiety neurosis, which is similar to functional dyspepsia. You have depression, pregnancy, and alcohol. Then going on, you have hematemesis, where you have upper GI bleeding, which indicates bleeding proximal to the duodenojejunal junction. Basically, hematemesis is proximal to duodenojejunal junction. Because ligament of Treitz, it's called as, it is hematemesis. If it is right on, it can be okay, it is hematemesis. If it is beyond that, it will be changed. The form of the blood will be changed, so it will be something different. So etiology, it can be esophageal causes, it can be duodenal causes, it can be miscellaneous causes. Esophageal causes, you have varices, esophagitis, esophageal carcinoma, Mallory-Weiss syndrome. Gastroduodenal causes, you have erosive gastritis, erosive duodenitis, stress ulcer, peptic ulcer, gastric carcinoma. And miscellaneous causes, you have rupture of aortic aneurysm, you have coagulation of defects, and you have vascular malformation. So if blood is in vomitus, bright blood is rapid hemorrhage, ground coffee appearance. This is a small bleed. Marina is black tarry, foul smelling stool. 60 ml of blood is required to produce melena. It must remain in GIT for 8 to 14 hours to produce melena. So you have signs of pallor, shock, syncope, features suggesting severe bleeding, and you have fresh blood in the nasogastric aspiration. There is clots in the vomiters, hematogesia may be there. Hematogesia is suggestive more of lower GI bleeding, but I think they're not thinking properly when they type this. Hypotension and tachycardia will be there. Orthostasis, which is change of pressure position from supine to sitting position, leads to fall in systolic blood pressure and raise in pulse pressure more than 10 mm, more than 20 beats per minute. So investigations, you can investigate using hemoglobin. You can do hematocrit. Blood urea creatinine ratio will be more than 72. It indicates upper IgA bleeding. And coagulation profile, you can check liver function test, ECG to rule out acute coronary syndrome, and nasogastric aspiration, upper GI endoscopy, and angiography. So management of this condition, you have gastric lavage, you can do proton pump inhibitors, you can do antifibrinolytic drug, which is tranexamic acid. Balloon tamponade can be utilized, vasopressin, acryolide, endoscopic therapeutic, electrocoagulation. Surgical methods, you have electrical stent surgery, transaction devascularization of the esophageal varices, and total gastrectomy. Some procedures: total gastrectomy in the surgical measures, management you do gastric lavage, proton pump inhibitors you do, balloon tamponade, vasopressin, acryolide, endoscopic therapeutic electrocoagulation, antifibrinolytic drug, which is tranexamic acid if it is vascular causes. That's basically how you deal with hematemesis. Investigations, of course, you have hemoglobin, hematocrit, blood urea creatinine more than 72, which is upper GI bleeding, coagulation profile for the coagulative causes, miscellaneous causes, liver function test, ECG to rule out acute coronary syndrome, nasogastric aspiration, in acute coronary syndrome to heart attack and all, nasogastric aspiration, upper GI endoscopy, chronic diarrhea and acute diarrhea. Vibrio cholerae, ETCC, and E. coli, Salmonella, Shigella, Campylobacter, Yersinia, enterocolitis. Viral, you have rotavirus and adenovirus. In the parasitic Giardia, Cryptosporidium, entomivia. Drugs, you have laxative sorbitol, lactulose. And then alcohol and antibiotics. Chronic diarrhea, it is caused by chronic inflammation. Salmonella, TB, Giardiasis, onguloids, Cryptosporidium, Mycosporidium, etc. Inflammatory bowel disease, ulcerative colitis, malabsorptive syndrome. Endocrine, you have Zollinger resistant syndrome, hyperthyroidism, carcinoid, non-beta cell pancreatic tumor, villus adenoma. And motility disorder, you have non-irritable bowel syndrome and post-vagotomy syndrome. Malabsorption syndrome is actually refers to a defective absorption of essential nutrients, electrolytes. Etiology is defective in luminal phase, mucosal phase, or consort phase. And I feel this is not that important of a topic. I don't think they ask malabsorption syndrome. You guys have any doubts? No one in chat. Well, that's life. Let's see. Okay, malabsorption syndrome, it refers to defective mucosal absorption of essential nutrients, electrolytes, minerals, and vitamins. It is defective in luminal phase, it can be mucosal phase, or it can be transort phase. So luminal phase defects, it can be substrate hydrolysis defect where there is enzyme deficiency, chronic pancreatitis, pancreatic carcinoma, enzyme inactivation, Zollinger-Ellison syndrome. You have rapid transit, which leads to post-gastrectomy, gastric surgery, fat stabilization defect, which leads to decreased bile salt synthesis, parenchymal liver disease, and you have impaired biliary secretion, leading to cholestatic jaundice. So, increased bile salt loss, terminal ileal resection. All these, like parenchymal liver disease, leads to decreased bile salt synthesis, cholestatic jaundice leads to impaired biliary secretion, and terminal ileal resection leads to increased bile salt lost. Luminal availability defect, lack of intrinsic factor, pernicious anemia, blind loop syndrome, bacterial overgrowth. These are luminal phase defects. Mucosal phase defects, you have brush border hydrolysis defect, which is disaccharidase deficiency. You have epithelial transport defect, which is Hartnup disease, cystinuria, intestinal resection, celiac disease, tropical sprue, Crohn's disease, radiation, ischemia, Lipper's disease, and it's all lead to epithelial transport defect. Epithelial processing defect, you have beta-lipoproteinemia. Beta lipoproteinemia. A beta lipoproteinemia. Okay. Then transport phase defects on lymphatic obstruction, lymphangiectasis, and vascular intestinal ischemia, SMA, stuff like that. So you can also be due to drugs. Colchicine inhibits script cell division. Neomycin leads to precipitation of the bile salt. Methotrexate, folic acid antagonist, and cholecystramine binds to the bile salt. And laxatives, you have multiple mechanism in lactone. And systemic diseases, it can be due to Addison's disease, it can be due to thyrotoxicosis, hypothyroidism, diabetes mellitus, collagen vascular diseases. So treatment includes correction of the nutritional deficiency, where you need gluten-free diet in celiac disease. Celiac disease, you eat gluten-free diet, pancreatic enzyme replacement in pancreatic insufficiency, low-fat diet, cholecystramine, and bile salt deficiency. If there is a replacement therapy, you have to do replacement therapy. Oral folic acid, oral iron, intramuscular B12, vitamin D and calcium, and electrolyte correction should be done. Treatment of the underlying disorder should be done. So clinical features, you have insidious onset, gradual progression, general features of diarrhea, abdominal pain, abdominal distension, loss of weight, anemia is seen. Then specific features, you have due to defective absorption of different constituents, protein will lead to emaciation, pitting edema, pitting pedal edema. Fat will lead to loss of weight, steatorrhea. Carbohydrate will lead to abdominal distension, belching, bloating. Vitamins, vitamin A, D, C, and K, vitamin B1, B2, vitamin B3, and vitamin B12, folic acid. All of them lead to their own respective stuff. Vitamin D, tetany, D is tetany, and osteomalacia, stuff like that. All of these will be specific features. Due to defective absorption, it will lead to all of these. Steatorrhea, fat, emaciation, epidemia, diarrhea, abdominal pain, abdominal distension, loss of weight, and anemia will be there. Gradual progression is there, and it is an insidious in onset. So as far as investigations go, you can do Perrin wheel. It'll rule out any specific structural abnormalities, and you can test for fat absorption. Sudan staining of the stool for fat globules can be done. Fat globule excretion in 1 day is more than 7 grams. Normally it's less than 7 grams on a 100 grams a day of fat diet. And measurement of fat soluble vitamins, you have A, D, E, and K levels in the blood. You can measure them. Okay. So test for carbohydrate absorption, you have glucose tolerance test, you have low blood sugar level, and you have the xylose absorption test. So lactose tolerance test, you have hydrogen bath test to diagnose lactase deficiency. And for tests for protein absorption, you have serum albumin level. A test for bile salt malabsorption, you have serum selenium homocholic acid, taurine, which is SCHCAT test. You also have wireless capsule endoscopy and small intestinal biopsy. So right now my pen is somewhat charged. I am going to start using it. Give me a second. I'll just write come back. I'll write come back for this one. This one also. Yeah, and I'll go to Okay. Do you have any doubts? Even in the chart. Okay. Just give me a second. I'll be right back.